And I just wanted to start by pointing out some parts of the ESG guideline on Barrett's esophagus. And I'll start with a no-brainer. Like the discussion we had this morning, do you have to clean during your upper GI endoscopy, and will that improve lesion detection? We said it's a no-brainer. We don't need much research to say that cleaning helps. And the same, I think, holds for this recommendation, because in the guideline, we advise a minimum of 1 minute inspection time per centimeter of Barrett's esophagus during surveillance endoscopy. There has been a study looking into this, and there has been some critiques on this study, that there were some drawbacks, etc. But I think the bottom line is that it's also a no-brainer that if you inspect longer, that you will detect more neoplasia. So make sure that you have enough time if you're going to do a Barrett surveillance endoscopy. It's not only that you look longer, but you also need the time for cleaning, for pull-throughs through the Barrett segment, for virtual chromoendoscopy, and for accurate photo documentation. So you just need the time and just take it as well.
So I've only introduced. I'm at the top of the esophagus. We haven't done any cleaning yet, so for me it's also a surprise what we're going to find. So I'm going to focus on the stomach in this case. So I'm going in. We have a cap on the tip of the endoscope, using a little water to flush already, because I prefer my image to be clean. And then we move in just slowly, not to miss anything big in the esophagus. And then moving ahead. The first thing I notice is a normal G junction, so there's no Barrett's, no esophagitis. Then go into the stomach, and actually it's already, you see some bubbles, there's no food remnants, so that's a good start. So what I'll first do is just suck out the fluid that's there. So there's always this puddle of fluid here in the fundus. So a little bit of insufflation and suctioning at the same time. Then I do a quick dive into the antrum. I don't bother too much with what I'm looking at the moment, just want to see if there's no solids there. There's not. So what I then would like to ask the nurse is, already extremely well prepared for some infocals, simethicone. So usually this patient is intubated, so there's no risk of aspiration, which is a good thing. But also in patients with normal sedation, put them in a little bit reverse anti-Trendelenburg. And then I just put in the whole syringe of this infocal. And then we'll just do another one, because in this case we really want to, thank you, appreciate how the stomach looks. And pull back a little bit. Okay. And what I then do is that I'm not going to suck out the fluid at this moment, I'm just going to suck out the air. So the stomach collapses and the infocal can touch as much as the mucosa as possible. So I'll get out the air here, then I move up, get out the air, and only then when I'm in the top again at the fundus, I'm inflating and suctioning away the fluid. So that sort of maximizes the effect of the infocal. So we put in about 2 big syringes, so a lot of fluid also to suck out again. It doesn't take a lot of time, and it really helps you afterwards. And then while insufflating, try to move where the fluid is. It's always up there in the fundus.
It's already showing what you just said, isn't it, David? There's some high-risk patients, and it's very convenient. We can do this under general anesthesia.
Exactly. Yeah.
Putting in a lot of fluid, taking your time to make it all clean. And
yeah. And in this case also we have a cap on the endoscope already, because this is a high-risk patient. So this morning I discussed this, I usually start without a cap, but in this case we know that we will be focusing on the mucosa in more detail, so we already have it on there. So there's, it looks quite okay now, just a little bit of bubbles. So this is, I think, the good moment to start the inspection, get out the rest of the fluids.
Hello, Ross. Very beautiful case. I was discussing with Russ, with Raf. Could you show us the peak pattern of the fundus and then the pit pattern of the antrum and maybe also of the scar. Sometimes this can be challenging, but let's see if we can see the round pit pattern or not, because maybe this patient has gastritis in that region, so we will see.
We will first start here, very proximal in the stomach.
We don't see signs of atrophy in this patient.
So we will zoom. So I'll put in a little bit of water.
Yep.
You can zoom in. And
You can see the round pit things that I was talking about.
Yeah,
and
very beautifully.
are you using? Could you put? Yeah, if you put a little bit more zoom, the tiny brown spot that we have in the middle of the circle, that the crypt, the opening of the crypt. So that's a very beautiful image, and around the crypt we have the subepithelial capillary, and that's a very nice image to understand histology, and that's the straight funding gland, the opening of the straight funding gland.
Yeah, and I think the good thing of this zoom scope that you have this virtual zoom, but you also have even more optical zoom, so that really allows us to have this crisp, clear image of the crypts.
And this is not to look smart, to say that these are round pits. This is to know that this is normal. So that's why it's very important to recognize this.
And I think even without that amount of zoom, it's for everybody easy to recognize normal round gastric pits in the fundus and in the corpus. This is not an expert thing, right? So you look at it once, twice, and then you know it. And if it's like not, if it's fillers, then you know there's something wrong. You take biopsies.
Is the presence of folds and a lot of folds there also a surrogate sign for you, Enrique, that it's not particularly atrophic? Is that what you were looking at when you went in and saw that, or that's not relevant here?
Yeah, and also when we see a large gastric folds, that could be also a sign of inflammation, and that's probably the case. If we know what is normal, then we are in a position to understand what is glandular atrophy. Histologically speaking, we lost the glands, and this has an endoscopic impact or a translation into what we can see. It is important that we are better at detecting intestinal metaplasia than at detecting atrophy. But there are some signs that were already shown by Raf during the live case, such as paleness, the visibility of some mucosal vessels, the reduced or absent gastric folds, but we need an adequate amount of air insufflation. Otherwise, there can be false positive and false negative patients. And finally, we can also see the presence of an atrophic border. Here we can see the atrophic border, which is a concept slightly different from the demarcation line. Here we can see that there is remaining healthy mucosa and then the atrophic area. Then, when a patient has atrophy, some of them can be at increased risk of gastric cancer when they develop intestinal metaplasia.